Good morning, Peter Goertz. I'm a psychiatrist. Is our mental health system broken? Or maybe a better question would be, how broken is our mental health system? And analogously, how broken is our medical system? Now, the other side of that coin, and there's pretty much always a silver lining, the other side of that coin is there's room for creativity and improvement. There's opportunity for the next generation of doctors, for instance, to make major changes that can be very helpful. So there's really good side to this in that sense. One major challenge in psychiatry, at least, is it can take a long time to get an appointment to see a psychiatrist. Months, people wait months to see me as a new patient. And that can be a real challenge. Just imagine someone's in a crisis, not quite bad enough to end up in the emergency room, but pretty unstable, really suffering, and they have to wait months for an appointment. So that's a really difficult situation. And similarly, for psychotherapy, patients often have to wait a long time for psychotherapy. Even for intensive outpatient programs, day programs, they have to wait a long time often. And then, as a psychiatrist, you may be asked to see many new patients, and all of those patients require follow-up. So if your schedule is full and someone is not doing very well, they may have to wait 3 months to see you again, which again is a major problem if they're not doing well. So there's a lot of shortage of psychiatrists, for example, and that drives part of this problem, but there are many other aspects also. For example, there are many urgent care clinics in the city where I practice. However, to my knowledge, except for at the VA maybe, there's no urgent care clinic for psychiatry or for mental health. So that is a real problem. So that's an idea actually for someone to work on, a mental health clinic for urgent care visits for mental health patients. So what happens often is people cannot get appointments to see a psychiatrist. There's no urgent care clinic for psychiatry, so they end up in the emergency room, which they may not have needed to, and the emergency room visits are much more expensive than urgent care or even less expensive clinic visits. So that costs the whole system a lot of money, costs insurances a lot of money, and that happens not infrequently. I had a patient yesterday whom I was seeing in an emergency room, and he was not doing well. He wanted a medication change. He was anxious, depressed, and he was not able to get an appointment with his outpatient psychiatrist, and the outpatient psychiatrist was not able to talk with him on the phone and make medication changes, which I understand because that can take some time. You want to talk about the pros and cons and which changes you want to make. So this gentleman ended up in the emergency room and we made the medication changes, and hopefully that'll be helpful. But the cost of that visit is enormous, which could have been just a basic urgent care visit or even a scheduled clinic visit, even better. But again, there was no time in the psychiatrist's schedule. Insurances, like I kind of mentioned already, can be a major problem. And for example, if the medicine that you want to prescribe for a patient is very expensive, the insurance may not want to cover it, and the unfortunate part is that can be a recurring thing, or another unfortunate aspect is that can be recurring. Some medications, the insurances want to apparently reassess every year in order to potentially cover or not cover, and the finances can be exorbitant. If the insurance doesn't cover the medicine, the patient cannot do well and, for example, end up in the hospital, medically or psychiatrically. Another aspect with medications briefly and money is that the brand name medications often are more expensive, so people tend to want to use generic medications. The insurances, at least, would like people to use generic medications, but one aspect of generic medications is they may not be equivalent. So one company's generic version of a medication may be preferable, made better than another company's generic version of a medication. And that, in my experience, is seems to be obvious with different preparations, different generic versions of Wellbutrin XL, which is bupropion, an antidepressant. So the generic medicines by different companies are not necessarily equivalent. That's another aspect, and that's also connected with money, of course, because they want to make them in a way that's not expensive, and that may end up creating medicines that are not necessarily as effective. For instance, the Wellbutrin XL may release too much Wellbutrin in the early phase instead of being extended release. So they may get a rush of Wellbutrin, which can be a problem. So again, consequences can be a problem. People, if they cannot afford their medicine, I'm remembering another patient on an antipsychotic. He ended up, the insurance was not covering very well, and he ended up not being able to afford the antipsychotic and ended up taking a less expensive antipsychotic, which was a major problem because he did not do well on that one, not nearly as well, and ended up taking a very high dose without the doctors, without my consent. So he just ended up on his own taking much more. And he had actually ended up, and that can have major consequences. This gentleman unfortunately ended up in the ICU then. So things start out with a financial issue, but they can end up creating a major problem, including, like I said, the ICU admission. Another aspect of saving money in our system is instead of psychiatrists, for example, or even internists, for example, any specialty of doctors, hospitals prefer often to hire nurse practitioners or physician's assistants, and they're generally very competent people, and they cost less money for the hospitals. However, it's a trade-off. It creates a trade-off because some situations the nurse practitioners and physician's assistants may not feel as comfortable dealing with. For example, older patients in psychiatry, for example, older patients with a complicated medical history, the nurse practitioners and physician's assistants may not feel as comfortable dealing with those patients. And if you have a lot of nurse practitioners and physician's assistants in a clinic and you don't have a lot of psychiatrists, then those older patients with a complicated medical history end up having very little availability for appointments, which is then a consequence, again, of trying to save money. So another aspect of our mental health system that may not mean that it's broken or not, but another aspect that a lot of people do not feel comfortable with, including myself, it's really something that I've never liked, is involuntary treatment. And you especially see that in psychiatry, but also in other specialties. Let's say if a demented patient is refusing a procedure that's urgent and would be life-saving, then someone else, a family member, may have to step in and make decisions for that patient, even if they don't want the procedure. So there can be involuntary treatment, even in other specialties, but it's especially common in psychiatry. And if someone's psychotic, part of that often is, part of the psychosis is lack of insight. So very often psychotic patients do not believe they're ill, and of course they don't want to take medication for the psychosis. So it's almost an inherent problem in psychosis that if treatment is not involuntary at some points, there will not be treatment and the patient will do very poorly. But again, it's something I don't feel very comfortable with because ultimately, in my opinion, in the long run at least, if treatment is not voluntary, it's very hard to have a successful treatment, in my opinion. And all these things are connected, all these things I've mentioned today are connected with social aspects, and they can really affect people's mental health in a major way. For instance, I have a patient who recently retired, and he's doing much better psychiatrically. The job was so stressful that he was taking a good amount of medication, but now after retirement, he's taking less medication, less psychiatric medication, and doing much better psychiatrically. Another aspect is a lot of people are very isolated in our society, but if they get into a situation where they have more social contact, they may need a lot less psychiatric medication and do a lot better. Thank you.